Welcome to the Public Health Practice Grand Rounds for March 2010. My name's Molly Mitchell, and I'm the coordinator of the Mid-Atlantic Public Health Training Center. And I'd like to welcome everybody to today's presentation on improving healthcare incentives, cost effectiveness, and public policy. And these Grand Rounds are co-sponsored by the Mid-Atlantic Public Health Training Center and the Department of Health and Mental Hygiene. And before we begin today's presentation, I'd like to invite those of you who are watching online to view our available online and face-to-face trainings that are coming up. In addition to the trainings available on our website, such as public health nursing and the many archived Grand Rounds, our upcoming trainings include our core competency training series with Dr. Carolyn Fowler, including the community assessment and formative evaluation, as well as using social marketing principles to influence decision makers. And next month's Public Health Practice Grand Rounds on April 21st on gonorrhea and the fading treatment frontier with Dr. Anne Marie Rompalo. And for those of you watching online, we do ask that you take just a moment to fill in our sign-in sheet if you're watching with a group. That'll help us have a better count of how many people are watching our webcast. Let's see. With that, I'll go ahead and start and introduce our presenters for today. Dr. Kevin Frick is a health economist and professor in the Department of Health Policy and Management at the Johns Hopkins Bloomberg School of Public Health. He has worked extensively on cost-effectiveness projects, with the projects including studies conducted alongside randomized trials, studies modeling specific pharmaceutical products or other medical treatments, nursing interventions focusing on pediatric asthma management and breastfeeding, and broad public health interventions, such as an older adult volunteer program that is intended to promote the health of older adults, improve educational outcomes for children, and build social capital. He's focused on finding ways to make the results of cost-effectiveness studies useful for and interpretable to diverse audiences, including nursing researchers and eye care professionals. He received his bachelor's degree in health policy and administration from Pennsylvania State University, and master's in economics and PhD in health services research and economics from the University of Michigan. And our second presenter today, Robert Murray, is the longest-serving executive director of the Maryland Health Services Cost Review Commission, having held that position for the past 16 years. Before joining the HSCRC, Mr. Murray worked as a senior manager in the healthcare finance division of Ernst & Young. As executive director, he is the administrator of the nation's only all-payer hospital rate-setting system, an industry of 47 general acute care hospitals with revenues in excess of $13 billion annually. During his tenure, Maryland has experienced the second lowest absolute rate of growth in hospital costs of any state in the U.S. Under Mr. Murray's leadership, the Maryland rate system has initiated a number of highly innovative incentive-based payment mechanisms to improve hospital efficiency and quality. Mr. Murray also serves as a member of the board of directors for the Maryland Health Insurance Plan, the high-risk insurance pool for the state. Mr. Murray is a frequent lecturer and presenter internationally. He's also worked as a short-term consultant for the World Bank on a number of assignments related to healthcare reform initiatives in the Russian Federation and Brazil. He received his bachelor's and master's in economics and MBA degrees from Stanford University in Palo Alto, California. With that, I'll hand it over to Dr. Frick.
Well, thank you for the invitation to present. And today we're talking about incentives, cost effectiveness, and public policy. So to think about what we want to learn from today's discussion and what we want to take away, we want to be able to understand what are the difference between cost effectiveness and cost benefit terms. And we think about it both in terms of academic things that we would see published as articles and how it would affect policy or how it would affect practice, and how we use this information to help think about and change what's going on. And then once I've done that, I also want to outline a cost effectiveness study and think about applying it to an exemplar that would be relevant to a public health audience. And to get there, first I want to talk about what exactly is health economics, because health economics is difficult to define field in a lot of ways. It means a lot of different things to a lot of different people. So I want to clarify where I think it's coming from, and obviously with the terms incentives and cost effectiveness both in today's title, that helps to characterize what I think a lot of health economics is. What are the many different types of cost studies, and then how to apply these to a particular intervention. So first, to begin then, what is health economics? Historically, there's terminology called positive and normative use of economics, and just sort of running through what that means. Positive uses of economics are developing theories of expected responses to changes in incentives. So to think about how changes in prices, changes in the time that it takes to get to medical care, changes in the availability of medical care, how those things will affect the behavior of individuals and organizations. The economists develop the theory. They then see whether people and organizations respond in the way that they expect them to. And one key is that economists don't make an assertion that people should value things in a certain way. They observe and see whether or not the behavior is consistent with assumed motivations for behavior, rather than necessarily saying everyone should be concerned about a certain thing. It's key that in the positive side, we're testing whether the assumed objective, whether it's to maximize profits for for-profit healthcare providers, whatever the objective might be for not-for-profit providers, whether or not that objective seems to be the case based on behaviors. And then if the theories don't seem to be explaining behavior correctly, to revise the theories and go back and test it again. The so-called normative use of economics is asking whether there's something wrong with the market, such that government needs to impose a regulation or change an incentive. Use data then about the trade-offs that individuals are willing to make in terms of how we value things. Aggregate up these preferences and assume that this represents the trade-offs that society as a whole is willing to make. And then we have to project changes in health or other outcomes with an innovation in care or an innovation in policy in order to try to assess what the effects would be. And then compare the cost of the innovation with the benefits of the innovation, however we might measure that, and make a policy recommendation. And it's interesting because sometimes these two parts of economics don't talk to each other very much. You have people who are doing policy analysis looking at behavior and people who are doing cost effectiveness studies, and sometimes they don't talk to each other. But I think it's really all part of one big loop that sort of shows how policy goes. So we observe a behavior that we don't think necessarily is the behavior that we want to be encouraging. Make inferences about the reason for that behavior based on economic theory, and it can certainly be informed by other theory as well, particularly in a school of public health setting where economics is not the only thing that we assume motivates people's behavior. So that's the positive side. Then, having looked at the behavior and looked at what's motivating it, develop interventions to change it. Then you can do an economic evaluation of the interventions, the normative side, which leads to a recommendation for policy, and you can see we're getting back to the completion of the cycle here. Adopt the new policy. Almost invariably, things don't go as we planned for them to, and we get back to observing behavior and starting the process over again. So again, this is representing how economics, both in terms of being used as a science to explain and look at behavior, and also being used as a science to do an evaluation of policy alternatives, fits into one large cycle. Now, when we look at the literature and we think about how we can use economic results to have an impact on policy and practice, we see many different types of cost studies, cost effectiveness, cost benefit. There's studies out there called cost consequence studies. And so one of the things that I want to do is just lay the groundwork for understanding what those different types are. I think it's also important to recognize that one thing that we hear about in the literature quite a bit is comparative effectiveness, particularly over the past year. The Department of Health and Human Services at the federal level had a lot to say about comparative effectiveness. What's interesting is that for the term comparative effectiveness, there are multiple definitions internationally, and even multiple definitions within the United States. None of them are cost effectiveness. And it's worth a quick review of at least one of the definitions to help understand what it's getting at, and then how it fits with cost effectiveness. So this is a slide with a lot of words on it, and I'm just going to summarize what we see. This is the official Department of Health and Human Services definition that was released last year. Comparative effectiveness research is the conduct and synthesis of research comparing the benefits and harms. So particularly with the discussion about mammograms for women in their 40s a couple months ago, the harms were an important part of that discussion, of different interventions and strategies to prevent, diagnose, treat, and monitor health conditions in real-world settings. So again, a few important terms to recognize. We're not just talking about medical care interventions, we're talking about strategies. So it can be public health strategy as well. It could be for prevention as well as diagnosing, treating, and monitoring. And we're really worried about real-world settings. So not just how it goes in the lab, not just under tightly constrained randomized trial protocols, but when it's actually implemented in the real world. And the purpose of this type of research is to improve health outcomes by developing and disseminating evidence-based information to patients, clinicians, and other decision makers responding to their expressed needs, and then under specific circumstances. And there's a few other details that follow. The key, however, is that nowhere in that definition do you see the word cost. Not once. Okay? And I think it's important to recognize that because we certainly need all the information that's in this definition in order to make more informed, better policy and implement better practice. But we also need to worry about how much it costs. And whether we end up with a cost-effectiveness study or some other type of economic evaluation, the key is we have to take the information we get from comparative effectiveness, combine it with information on cost or other economic measures, and then make a policy recommendation at that point, and hopefully not try to recommend policy only on the comparative effectiveness, regardless of how much it costs. So here's a chart where we've got different types of analyses and different types of outcomes, and again, to help structure our thinking about how these studies fit together and how we might be able to use them to inform policy and practice. So one type of analysis, again, that we hear about quite often is cost effectiveness. And the thing about cost effectiveness is that not only do we hear about this type of study, but it's also the case that the word cost effective just sort of permeates the literature. You know, is this cost effective or not? Sometimes when people use that terminology, they're simply asking, is it cost saving, rather than asking, is it cost effective? Because to be cost effective, it might cost more, but if it gets us enough of a better health outcome, then costing more might not be such a bad thing. So the key, though, when we have a cost effectiveness study is that we have a single most important outcome in what are called natural units. And one time somebody asked me, what's an unnatural unit? And it's not that we're comparing natural and unnatural units, but things that we can measure, things that are mostly clinical measures, blood pressure changes. If we're talking about diabetes patients, hemoglobin measure changes. I've done work with ophthalmologists and other eye care professionals, so if you're worried about visual acuity, if you're worried about obesity, we could look at BMI. And these are all things that we can measure clinically and we can get an exact measure on. And we can compare those with constructed measures, particularly thinking about quality-adjusted life years, if you've heard of those, disability-adjusted life years in dollars, that are a little bit more abstract in terms of how we get to them rather than just going to the patient and making a measurement. And the key with the cost-effectiveness result, then, is that we have some amount of money that it costs to improve an outcome. And we have to decide, then, is it worth spending that money to improve the outcome? Should we leave it to the market to decide whether it's worth spending that money to improve an outcome, or should the government make that decision? And when we think about it, you know, amount of money to improve an outcome, we can sort of think of that as a unit price. We use unit prices all the time in our day-to-day lives. We don't often think about the concept of unit prices when we think about health policy, but that's essentially what we're asking. And when we do a cost-effectiveness study, we have to answer the question separately for each possible outcome measure that we might have. So we have to separately understand, well, what is it worth to buy an extra year of avoiding blindness? What's it worth to buy an extra year of health for a person with diabetes? What is it worth to buy an extra year in which a person is not obese? Okay, so different measures. So one thing that economists have tried to do over time, then, is to come up with a measure that can help us to come up with a single unit price that might be applicable to everything. And that leads us to cost utility studies. Cost utility is a subset of cost effectiveness. It is expressed as an incremental measure, the dollars per something, but it's not a natural unit in the same way because we're using this concept of quality-adjusted life years or disability-adjusted life years. Quality-adjusted life years is typically what we use in the United States, and it's a fairly easy concept at an intuitive level, but not the easiest thing to actually then figure out how we're going to measure it. At an intuitive level, it combines morbidity and mortality. So how your quality of life is while you're alive, which can be affected by how sick you are, plus how long you live, gets combined into one measure. Now that's kind of a nice thing to be able to do because what that gives you then is the opportunity to think about every disease expressed as one measure, because whether a disease has multiple types of morbidities or whether we want to compare one disease with another, we can put them all on the same scale. Now, we see a lot of studies like this in the literature these days because about a decade and a half ago, there was a panel that had been convened by the Department of Health and Human Services that recommended that all studies be done with quality-adjusted life years as their outcome measure. Here, the advantage is, again, one outcome no matter what disease we're looking at, no matter what intervention we're looking at, and that's appealing because then we only need to have one unit price. How much should it cost us to buy an extra quality-adjusted life year? That still only goes so far, though, because when we measure quality-adjusted life years and when we measure costs, we're not measuring everything that's relevant to the decision-making process. And there's always something about ethics or distribution of cost or distribution of benefits that has to be considered as well. So we don't want to use just economics, but that's one of the most concise ways to use an economic evaluation to indicate whether or not something is worthwhile. But again, we don't have a formal policy in the United States saying this is how much we should be willing to spend to improve health by one quality-adjusted life year. Moving back to the top of the chart, we can fill it in with cost minimization. That's easier because there it doesn't matter what outcome we have. We have simply observed the two different types of strategies or programs or interventions have the same or very similar outcomes, and we simply need to ask from an economics point of view which one costs less. Again, we might be concerned about things other than economics, but the economic question itself is a very simple one. What's interesting is that if you see a cost minimization study in the published literature when you're looking at something to help make a decision, many studies don't start as cost minimization studies. They probably started as a cost effectiveness study with the researchers thinking that the effectiveness and the cost would be different. But it turned out that the two interventions or strategies had the same effect, and then all we have to do is compare the cost. So it makes it very easy to use that, but it also means that whatever new intervention you had, which you thought was going to be more effective, did not turn out to be. And similar outcomes doesn't necessarily mean identical. It can be similar in the terms of not statistically different from each other, or more importantly, whether they're statistically different or not, if it doesn't make a clinical difference in terms of one person's health or in terms of the health of the population, if it's really not that much of an important difference, then we might as well just treat them as the same and again ask simply which one costs less. Increasingly, we're seeing this type of study called a cost-consequence study. And a cost-consequence study, we have multiple outcomes in natural units. So if we think about that, you might think of it as researchers just sort of hanging up the towel and saying, well, I don't know what the most important one is, and I can't think of a way to get a summary measure like quality-adjusted life years. So I'm just going to tell you everything that happens and what the costs are. But there are times when it might actually be important to have multiple outcomes that we can't combine into a single final outcome. So in the introduction, it was brought up that I've been involved in a study looking at older adults volunteering, where we're trying to improve the health of the older adults, the educational outcomes of the elementary school children with whom they're volunteering, and then build social capital in the community. Okay, that's 3 different outcomes. And no matter how hard I might try, I can't think of a way to combine all 3 of those into a single metric. And so that would be a perfect candidate then for a cost-consequence study, where we say, here's how much it costs to have this volunteer program compared to not having it. Here's the outcomes for the older adults. Here's the outcomes for the kids. And here's the outcomes for the neighborhoods they live in. Now, you might say, well, that leaves the decision maker with a lot to think about because there's all these different outcomes and this comparison of cost, and maybe one intervention or one alternative is better on some of them, and the other alternative is better on others. But if you think about it again, we use lists of outcomes or characteristics of options like this in our day-to-day lives. If you're buying a car, if you're buying a house, maybe the one house is bigger, but it's in a not as great neighborhood for the elementary school and it's not as close to the highway, or maybe a car has some features you like but it's more expensive. So there are things in our day-to-day lives that we work with in this type of decision-making framework, and this is just bringing that decision-making framework to making health policy. Finally, cost-benefit studies. Cost-benefit, we express the outcomes in dollars. Particularly if we're trying to prevent something, we could think about how much monetary burden is avoided. So an easy way of thinking about cost-benefit, before I talk a little bit about return on investment, is to think about influenza vaccinations. Okay, you spend money on the vaccinations, you avoid people getting influenza, so it's easy enough to put a dollar figure on the avoided hospital admission or the avoided trip to the doctor's office for the person with influenza. It's a little harder to put a dollar figure on how much it's worth if the person doesn't suffer from mortality because of getting a complication of influenza. So cost-benefit is nice that it gives us dollars, and we can just compare the size of the benefit with the size of the cost and just ask which one is bigger. However, there are some things like the value of health and the value of life, if we're talking about mortality, that are in fact difficult to put a cost or a dollar figure on. Now, all of those are the types of things we tend to see in research. What's interesting is that if we think about what a healthcare organization or a local public health department or a statewide health department needs, it's not always measures like quality-adjusted life years. And we're often interested in trying to boil everything down to dollars and cents, but that doesn't mean we're going to be interested in a cost-benefit study as it would be published in the literature in all cases. Cost-benefit studies in the literature tend to look at the lifetime of the targets of the intervention, and they tend to take into consideration all of the costs to anyone in society who's affected by the program, and all of the benefits for anyone in society who's affected by the program. And that's great from an academic publishing point of view, but decision makers might be interested in a much shorter time frame, the next 3 years, the next 5 years, perhaps even the next 1 year, and they might be interested in a much more narrow list of people who are getting benefits or who are incurring costs. And so when we think about what we see in the literature and then trying to apply it to public health policy and practice, we have to think about, well, were the results expressed for society as a whole, and do we want to use those results as they were given originally in order to inform policy, or are we interested in results just for the healthcare system, a specific healthcare payer, or a particular provider or facility? And these are the types of things that we have to think about in terms of how we're going to interpret the results, or perhaps even the patient. And then if we're doing a return on investment analysis, that tends to focus on a particular provider or a particular facility that has to consider, is it worthwhile to adopt a new technology, implement a new intervention, or other type of program? So we'll go through a quick example before I hand it over to a discussion of sort of more policy issues. This is an example from a published study, and the program that was run here by the principal investigator, Chad Boult, is called Guided Care. And we have a practice-based team, so within a physician practice. It includes a registered nurse, 2 to 5 physicians, and other office staff. And the key is that the guided care nurse serves as a patient navigator. Okay? So her job was to perform a comprehensive assessment at home, and of course nurses don't have to be females, but all of our guided care nurses in the study were, create an evidence-based care guide, monitor and coach the patient monthly to help sort of coordinate care better, coordinate the efforts of all the patient's providers of healthcare, very important thing there, smooth the transitions between sites of care, promote patient self-management, educate and support family caregivers, and then facilitate access to appropriate community resources. So several steps that would be very important for trying to get a better and more efficient outcome for the patient and the best use of resources. So here's a few basic results from the study. This was looking at their care use for 8 months after the baseline, and these are annualized rates then. So the guided care recipients, and this was a controlled trial, so we had people who weren't receiving guided care and people who were. And the guided care recipients had slightly fewer hospital admissions, fewer hospital days, fewer skilled nursing facility admissions and days, less emergency department visits, and better outcomes on almost everything in terms of less utilization, except for a little bit more, a slightly higher average number of specialist visits, and a slightly higher number of tests and durable medical equipment results, durable medical equipment items. So the key question is then, how do we translate that into a cost, and for whom are those costs important? It's also important to note that in the basic analysis of utilization, none of those differences were statistically significant. However, if we try to think about how this would then result for a caseload for one guided care nurse, one patient navigator, if we assume that the nurse is going to have a 55-patient caseload, which seemed to be about what the nurses could handle given the job description they had, apply an average per unit cost to the different types of utilization we were looking at, the basic result suggests that for 55 patients, there would be a savings of $171,000. And then if we compare that with what it would cost to hire a guided care nurse in terms of her salary, her benefits, and other pieces of sort of administrative and office space, it costs about $96,000 to hire a guided care nurse as part of a practice. So a net savings of $75,000 is our expected value, and then the confidence interval does overlap with no savings at all. But let's just think about that $75,000 savings for a moment. The key for that $75,000 savings is that the practice is the one who would have to hire the nurse and spend the $96,000. The savings would not occur for the practice. The savings would occur for Medicare, okay? And so one key question then is, from a societal perspective, we might save money. But if the practice has to spend money while the Medicare program saves money, that doesn't seem like a way to encourage the practice to adopt this new approach to helping patients to manage their care better. And so one thing that we have to think about, and again, this is an important reason for understanding the distinction between the different perspectives that might be reported and the different perspectives that are of interest to public health practitioners and healthcare providers and policymakers, is just understanding who's bearing the cost and who's getting the benefits. And no matter how good it looks from society's point of view, does it make sense to all of the stakeholders? And if it doesn't, can policymakers take steps to make it so that there is an incentive for the practice to, in fact, spend the $96,000? Is there some way that the Medicare program can share those savings with the practice that adopts this or not? Because if it can't, then it would be very difficult to encourage practices to adopt this type of a plan. So, a couple takeaway messages. Again, under the current administration, the term comparative effectiveness has attracted an awful lot of policy attention. But as it's being implemented within our National Institutes of Health for research purposes, it's not necessarily going to be accompanied by cost data, while for policy purposes, it almost has to be accompanied by cost data. Cost effectiveness is a term that's broadly used to mean a whole bunch of things other than exactly what it means in terms of the narrow sense of a cost effectiveness study as published in the literature. And again, when someone asks you, is something cost effective, the first thing that you want to understand to help a policymaker is, are they really asking you whether it's cost saving, or do they actually want to know how much it might cost to have a healthier target population? And then finally, to change policy or to change practice, we often need to describe something that's over a shorter time period than academic cost effectiveness articles tend to focus on, and with a more limited perspective. And so as you read the literature and as you use it to try to make changes in public health policy and practice, you have to think about the fit, or more often than not, the lack of fit, between what was measured and reported on by what are usually very skilled and very highly qualified researchers, compared to what's actually useful for the organization or stakeholder that you're representing, and thinking about how these pieces fit together. So economics provides us with a very useful set of tools that help in the policy-making process and that give us information that can help us to get to a more efficient system. But we always have to make sure that we're not missing some incentives along the way so that we end up with unintended consequences. And again, that the research that's being done and the actual information needs of the policymakers match up as best possible. Thank you, and I'll hand it over to Rob.
Good afternoon. I was going to say top of the morning to you, but it's no longer morning. So thank you very much. My name is Robert Murray. Very happy to be here. Greetings to those of you here and also off in cyberspace. I'm the Executive Director of the Health Services Cost Review Commission. I'd like to try to pull up a lot of the great discussion that Kevin had up to a larger, broader level of actual policy development, how it occurs within the context of an all-payer rate-setting state for providing payment for hospital care. Also influences other sectors of the healthcare economy. And I guess then after I'm done, we'll sit down and be glad to take some questions. And click. Okay. I've done just an overview slide here. What I'd like to focus on initially is kind of a general summary of our policy development process, which follows very closely the structure that Kevin laid out in his presentation. But then try to focus in on some of the concepts that, and the constructs that Kevin also discussed in the context of cost-effectiveness analysis and more broadly cost studies, how those concepts really can be used in the process of policy development for payment purposes or trying to meet other goals, social goals in the health economy. Focus on the role of government and addressing certain market issues, market distortions, because I think there is a growing cognizance that there is a role for government to try to intervene, hopefully in as least of interventionist way as possible, but to try to address market failures as well as help coordinate various components of the healthcare sector, and even in a certain sense be an innovator in providing tools for the marketplace. In that sense, I'd like to talk about the background of the HSCRC, the Maryland All-Payer Rate-Setting System, in that context of cost-effectiveness analysis, trying to promote cost-effective behaviors and achieve other goals, and then focus really on where I think we're headed as a policy agency to try to promote the development of value for dollars spent, which is a fundamental concept, I think, of health cost-effectiveness analysis and also some of the cost studies that were just referred to. General policy development process, pretty straightforward, actually. As Kevin mentioned, our first activity is to identify the market distortions and other economically and socially less desirable outcomes in the system. We then try to identify specific policy objectives that we're trying to achieve that relate to those distortions or problems in a given market or system. Identify those behaviors that need to be changed, and then construct financial incentives necessary to change those behaviors and achieve those objectives. We also, simultaneous with that, it's very important, need to be very data-driven and collecting data in a uniform, consistent way and developing sufficient metrics to be able to measure both the current performance and then also changing performance and relative performance across the providers that we're regulating. And so as a result, our system, our agency is very, very data-driven in addition to using incentives in a very structured and heavy way. And then there's an iterative side to this, which is we observe the behavior, we observe the performance over time and assess how well we've achieved the objectives and then circle back iteratively to try to broaden and strengthen and align incentives to improve performance. Now, the issues with regard to cost effectiveness can help, and these principles can help guide policy making. And that's much of how I've tried to structure my presentation here, because that idea of creating more value in healthcare, that is better health per dollar expended on an incremental basis, is really part and parcel of what we look at in the health policy development process. And that is, as Kevin mentioned, cost effectiveness analysis or incremental cost effective analysis, more broadly other cost studies, are tools that can both guide decision-making and optimizing the use of scarce resources, but also help us look at that issue of value from a policy perspective and promote value in healthcare. Now, cost-effectiveness analysis has been around a long time. It was first applied in the healthcare sector in the mid-60s and championed by Weinstein and Stason in New England Journal of Medicine in 1977, where they said that limits on healthcare resources mandate that resource allocation decisions be guided by considerations of cost in relation to expected benefits. And so we're now just finally focusing, I think, more substantively from a policy standpoint, how we can finally realize these goals and objectives and principles of cost effectiveness analysis. And try to boil this down in terms of what I have seen as kind of the general paradigm for cost effectiveness analysis is that in looking at any given intervention, you start with the status quo, whatever that may be for whatever particular thing that you're studying, and you look at what will create the potential for more costs or less costs on those axes, and I've sort of transposed the axes here, not because I've done work in the southern hemisphere, but because it was handy for my presentation, what's more effective or less effective, and then look at those various quadrants and in terms of an intervention, an alternative that you're studying, and see which direction you want to try to move things to produce more cost-effective and also outcome-effective related results. And of course, these other quadrants, 1 and 4, the trade-offs are less clear because there are benefits on either side. But obviously, you want to move in this paradigm towards quadrant 3. Now, the framework for policy, as we see it, is to pull that type of basic principle up to how do we actually promote value? That is, spending less dollars for an equivalent outcome or spending more dollars for a much better outcome. And generally, we try to look at it in a much broader framework. The broader framework, the better. And by example, right now, our focus is more on price per unit or cost per unit, whereas it would be much better to focus on overall cost to the healthcare system or cost per capita, or as opposed to individual quality-related structures that are very narrow, like evidence-based process measures, to focus on things that are broader representations of quality for populations, risk-adjusted outcomes, and patient satisfaction. And then combine both the cost side and the quality side into this concept of value for money spent. Now, I'll try to pull this in the context of the system that we regulate, the Maryland all-payer hospital rate-setting system, because I really think that we are better positioned than any other state to try to promote this concept of value for money. Give you a little background on the HSCRC. We're the only all-payer hospital rate-setting system in the U.S. There used to be 3 others in New Jersey, New York, Massachusetts, all had all-payer rate-setting systems back in the 80s and 90s. We were established to address market failure in healthcare markets. The Maryland legislature realized that there was massive, as there continues to be today, massive market failure. That is, the healthcare market doesn't function as you would expect a competitively, a well-run, functioning market to perform. There were identified policy goals established by the legislature prior to the existence of the commission that we were directed to address. And they were cost containment. We were much higher on cost per adjusted admission than any other state. We were about 25% above the U.S. in 1976, and we were growing more rapidly. Expanded access. There were a number of hospitals back in the 70s that were on the verge of financial collapse, and there was a concern that if they went out of business, that the uninsured individuals that sought their care there would now have no alternative for treatment. There are considerable, and there were and there are today, even more I would argue, considerable issues with regard to equity and payment fairness. High levels of accountability and transparency, of course, was a goal. It's something that we also certainly focus on today and in strong measure. Financial stability for hospitals. The legislature wanted to also, as a quid pro quo for cost containment, provide a stable and predictable environment for hospitals. And then lastly, improve clinical effectiveness. And then we haven't really been able to get at this issue as well over the decades because of lack of metrics, and I'll go into some discussion about that later. And what we do is we establish payment levels for all inpatient care per case and outpatient services per visit, and use financial incentives, payment per case, payment per visit, across all payers in the attempt to change behavior to meet those policy goals. And as such, anybody who's taken an economics course, of course, knows that price is a mechanism to influence behavior in a given marketplace and also to allocate resources. And so price is very important in that it sends those signals that people react to both in terms of their own decision-making and also their decision-making for how they allocate resources that are under their control. In competitive markets, prices send those signals, and that normally results in economically efficient and effective outcomes. But in healthcare markets, prices do not send the proper signals for efficient allocation of resources because there are these market distortions and market failures that I referred to. And what we do is we try to establish price and mimic, in essence, the way a competitively functioning market would establish price to then achieve the goals that have been established for us and allocate resources more efficiently. Now, these prices, the way we establish them, we have the benefit of applying them across all payers because in our system, Medicare and Medicaid are players. They actually pay the rate that we establish, and they react to the incentives. And when we set a rate for a hospital, hospitals also have that ability to have that charged across all payers, and that's a very, very powerful dynamic. Our historical focus has been on a relatively narrow unit of measure, per case, per visit, and that's been a limitation. But like Medicare, we are in essence a dumb price fixer. That is, that we're not able to set prices as effectively as a competitive market, but that we do it as best as we can nonetheless. This is a quote from Tom Scully, who was the former Medicare administrator under George Bush. But really, I would argue it's a question of dumb and dumber, because going back to the initial legislation that established our commission, the legislators realized that the market did not function appropriately and would not achieve the results that were desired, either from an economic standpoint or a social standpoint. There are these things like suboptimal market structures within the healthcare market. Hospitals as virtual monopolies in isolated rural areas. Across the nations, hospitals have formed health systems and have generated a tremendous amount of negotiating leverage in the healthcare marketplace today. So they influence price because those suboptimal market structures. There's a highly fragmented payer and provider industry. There's a dominance of physicians and hospitals in making the purchase decision so that they're actually making both the buy and the sell decision for consumers. There's the uncertainty and the absence of consistent and accurate information for us as consumers to make informed decisions. The presence of risk and insurance, which insulates us from the cost implications of our decisions. And then also the nature of the product. It's really hard to shop when you're in an ambulance being transferred to an emergency room. A, you don't have the choice. B, you don't have the capacity to make that type of purchase decision. And these and other factors contribute to the price distortions that are currently in the healthcare market today and that suboptimal result. So while rate setting may be a dumb price fixer, the market has been even less effective in setting prices. And a quote by Paul Ginsberg, the Center for Health System Change. Now, our system is all made possible by the Medicare waiver. It's a waiver that brings in Medicare and Medicaid into this structure where we set the price, the unit price, or the per case price for the hospital, and Medicare and Medicaid pay that along with all other payers. As I said, that's a very, very powerful dynamic. We're the only state to have retained a waiver. It establishes that broad-based set of incentives that we apply to the market. All payers pay that rate. It allows for those uniform incentives across the board to try to achieve those policy goals that we mentioned. All payers also contribute equitably to hospital costs in the system, and those include social costs, things like the cost of providing care to the uninsured or uncompensated care. We also build in amounts to provide for the reasonable costs of teaching programs, medical education. So again, all payers are contributing equitably to the financing of those costs. It's a very broad base also for other initiatives in that we can build in incentives into the prices to try to induce behavior to meet other goals such as quality of care improvement. The waiver also brings in additional federal dollars, and there's a waiver test that we must pass on a quarterly basis to retain the waiver over time. And despite the fact that we may be kind of the Jeff Daniels of healthcare markets, that Dumb and Dumber analogy, we've done pretty well. And I would argue that we've outperformed the market over time by correcting for market failure and structuring payment to try to change those behaviors. And part of that is because the rate-setting approach and philosophy and tenets are very consistent with how a competitive market would function. There are things like avoid unnecessary intervention. Regulation can do both good things and also harm. So we really want to set overall standards and targets, but otherwise let decision makers have maximal flexibility in how they allocate resources. There's an emphasis on providing accurate information, timely information on performance. Prices reflect costs, and we spend a lot of time on this issue of pricing accuracy. Try to make sure that unit prices reflect unit costs, and aggregate prices per case reflect actual resource expenditure per type of diagnosis and case. And that itself, arguably, from an economic standpoint, will result in better decision-making and better allocation of resources. We set rates prospectively as opposed to retroactively. That is both good for predictability because hospitals, payers know what they're in for during the course of the year. And those prices are in place and act as constraints over a year that hospitals then respond to, hopefully, by lowering their costs. Hospitals are held at risk for a large part of their activities, things they can control, things like efficiency and quality improvement, things we can measure. But then we make adjustments for things that are beyond their control, things like their case mix, their mix of different patients, whether they have more severely ill patients in a given year versus another year, or their amount of uncompensated care that they experience. So there's a big emphasis on adjustments and fairness in the system. There's a focus on cost control, but not on controlling profits, because as in a competitive market, profits are a reward for effective and efficient behavior. And there's also a prohibition on shifting costs, in that we believe that hospitals should perform not by shifting costs to other payers or patients, but rather by lowering costs. That's the way a competitive market would function. And then lastly, there's the support of the hospital's social mission, both teaching, providing benefits to the community, and also paying for uncompensated care. And as I said, I think we've achieved some positive results. For one, we bent the cost curve. We've experienced the second lowest rate of growth of any state over this period, and I think this extends also into 2008. We were 25% above the U.S. in cost per case in 1976 and about 2% below in 2007. That basically cumulatively represents $40 billion that we've saved the state over that period of time in averted hospital expenditures. In that top blue line is the rate of growth, this is indexed back to 1976, of hospital costs nationally. And the bottom line is Maryland's slower rate of growth, so that the difference between those two curves cumulatively is about $40 billion. And interestingly enough, had the U.S. grown at the Maryland slower rate, we would have saved the nation $1.8 trillion. Now, a lot of that, of course, is through the magic of compounding, but it does get to that concept of bending the curve. And over a period of time, you can look back and you've really achieved a lot of savings. Other goal, second one, was access to care. As I mentioned, the legislature was worried about there not being a mechanism for financing uncompensated care. So we developed a mechanism to build extra amounts into hospital rates to approximate the reasonable amount of uncompensated care any hospital would experience. It varies by hospital, so a hospital like Johns Hopkins may have a little more than a hospital like GBMC out in the suburbs. But it is, again, incentive-based. It provides hospitals with an incentive to provide care to the uninsured because they know they have a mechanism to pay for that. Hospitals have that extra amount. The implications are we finance $1 billion of care to the uninsured through the system, and all payers pay their fair share of that $1 billion. It's built into the markup, which is the amount between their actual costs and what they charge. So during the course of the year, they'll charge an extra 7-8% to all payers, accumulate that, and that amount approximates the uncompensated care that they see during that year. Uninsured patients, unlike the rest of the United States, are charged the same amount as insured patients. You don't have these tremendous markups where uninsured are paid full freight elsewhere and private insurers get some sort of discount. And there's never been documented cases of patient dumping in Maryland, whereas before EMTALA, there were many, many cases of patient dumping elsewhere. Another thing is I would argue we have far superior payment equity, that issue of controlling markups. We regulate that markup between the rate and the actual cost and prohibit that cost shifting from one payer to another. Nationally, hospitals use their market leverage to shift costs. Medicare, Medicaid pay below costs. There's uncompensated care. And hospitals that have big market power in a particular area will now jack up their charges, their list prices, to private insurers. And then there's this shell game of negotiating discounts off of that. It's a very, very unfair process. And it's also a very non-transparent process. This dynamic completely undermines cost containment nationally, because if you can shift the cost, why manage the cost? So if you take a look at the comparison of markups in Maryland versus the US, and these are data from the American Hospital Association statistics, as of 2008, markups nationally, on average, are over 180% above costs. And in Maryland, the markups are regulated. They've been consistent at approximately 20% of cost. And that is largely that provision for uncompensated care that I mentioned before. And as a result of regulating the markup, there are no antitrust concerns in Maryland. Accountability, as I mentioned, was another priority of the legislature. In addition to our rate-setting responsibilities, there are responsibilities and authority related to disclosure of information. We have the best data set on hospital performance of any state, by far and away. And it's because we have the incentives for hospitals to provide that data, because we establish payment based on the data they provide to us. And so there's a focus on making the data publicly available, having them very timely. We have, for instance, patient-level data to us 30 days after the end of any given quarter. So the data sets that we're working with now are back through December of 2009. Hospitals and payers are the biggest users of the data. They compare themselves, the hospitals do, to their competitors. They look at how they're performing on a cost basis. If they see something their competitor is doing to lower their costs, they try to understand that better and adopt that in their own practices. Prices are readily available. We're posting prices on the web for hospitals on a case mix adjusted basis, so consumers or payers can go in and take a look. We have ideas to actually post bundled prices of hospitals and physicians to provide kind of a reference pricing function to the marketplace. And virtually all of our activities are performed in public. So anyone can come in to a commission meeting and participate, be there, understand, and all of our deliberations are performed in public. There's a high focus on financial stability and predictability as well. As I said, that was kind of the quid pro quo for cost containment handed down to us by the legislature. Our rates are set prospectively. Hospitals, if they know what their volumes are going to be, have a really good idea what their revenues will be for a given year and can budget very effectively as a result. Uncompensated care, they don't have to worry about, because that's largely paid for in the rates. And as a result of this stability, Maryland hospitals are recognized consistently and given credit pluses in bond rating evaluations by the municipal bond rating agencies. And in fact, Maryland year to year has the highest percentage of what are called investment grade ratings of hospitals. We're, on average, 60–70% of our hospitals are rated investment grade, meaning having access to the credit markets, whereas the national average is around 20–30%. So that stability counts for something. And even though our profits are a tick below what we see nationally, stability counts for a lot in that type of evaluation. And you could argue from an economic standpoint, there is far less risk for hospitals here because of the stability of the rate-setting system. So perhaps profits as a reward would not be as high over the long term. Now, some observations about quality. As I said, this is kind of a new area. It's an area of focus now. We do have a mandate to promote effective operation, but up until now haven't had the metrics. But I think we're uniquely positioned to lead the nation on hospital quality. We have a very comprehensive payment system which generates very, very useful administrative data that we can link to quality measures and development of quality measures. We have the most sophisticated risk adjustment system that we apply in the context of the payment system that can also be used for adjusting for variations in patient mix in measuring quality. And as I said, a very, very extensive administrative data set, and the ability to structure incentives across all payers to improve quality. Not much progress until now, but I would argue we're leading the nation in linking payment to quality. First, with these evidence-based process measures. There are 19 that we've established in areas like acute myocardial infarction, pneumonia, heart failure, surgical infection prevention, just to show that hospitals are adopting evidence-based practice standards and then linking that to payment. Also, we're now focusing this year on looking at hospital-acquired complications. We're measuring some 49 of those and then linking performance on those on a risk-adjusted basis directly to payment in this year, 2010. We have plans in 2011 to evaluate hospitals on the basis of potentially preventable readmissions. Again, risk-adjusted, linked to their payment rates. And then eventually looking at other measures of quality. And of course, there's a cost component to quality as well. These are the four phases that I mentioned. First, starting out with process measures, then potentially preventable complications. We estimate there are close to $500 million of savings that we can generate in a system of $13 billion, so it's measurable in a given year. And then moving, hopefully quickly this next year in 2010 to implementing a system around preventing readmissions. And then lastly, building in other measures like patient experience of care or satisfaction, also linked to measures of safety. These are the tools that we're using in phases 2 and 3. They're basic metrics that are developed that are linked into our payment system, potentially preventable complications. I won't read the definition, but they are acquired at the hospital itself, risk adjusted across each facility for differences in patient mix, and then linked into payment, and then potentially preventable readmissions. These are tools that are available in the marketplace that link directly into various payment structures. Click through these quickly. These are 35 of the most significant potentially preventable complications that we're measuring hospital performance are. Now, some of them include hospital-acquired infection rates, but you can see it's a much broader set than you see anywhere else. Medicare implemented their own payment structure, but they were largely based on complication rates that were very, very narrowly defined. Never events. There were only 11 of those particular complication rates. Our goal was to try to do something that would be much broader, that could apply to all hospital service lines and product lines, and measure quality more extensively. So back to this concept of promoting value for healthcare spent. I mean, this is the chart that I showed before, where we're aiming on a given intervention basis from the status quo down to quadrant 3. And so that we would have an intervention that would be both less costly and more effective from a quality standpoint. But public policy can be structured to achieve that same sort of goal or try to move the system in that same direction. And so as a result, what we've tried to do is measure hospitals on those two scales as well. On the vertical scale, on a case mix adjusted charge per case or cost per case basis, high to low, adjusting for a myriad of differences across the hospital. So it is an apples-to-apples comparison. And these dots represent Maryland hospitals. And then on the horizontal scale, looking at risk-adjusted rates of complications across those 49 complication rates, so that you could see which hospitals are lower cost on those two dimensions and also higher quality. And they're the hospitals in that quadrant 3 in my example. And our goal as policymakers are to put incentives in the system linked to payment to try to move the industry more to that quadrant 3 over there. And then back to the policymaking and decision-making process that Kevin referred to and that I had as one of my first slides, there's the iteration. Our next focus is to broaden, strengthen, and align incentives to achieve better results. As I mentioned before, heretofore, our approach has been very narrow, per case, per unit, process measures. But a broader policy framework can provide more value to society. So we focus on broadening the unit of payment to include more services and more providers. Examples of that would be case rates, which would bundle hospitals and physicians together into a payment amount that would be analogous to the DRG. We're also looking to align incentives across hospitals and physicians through various gain-sharing mechanisms so that you flip the incentive of the physician or the hospitalist, which was previously the more they do, the more they got paid, to the alternative, which is the less they do, the more bonus they would earn, which is more consistent with the current incentives the hospitals are under. Also looking at, and we have established in some limited cases, global budgets for individual hospitals. They're more successful in outlying areas and rural areas, but if you cap a hospital's expenditures, immediately they move away from generating volume to try to generate revenues to increase profitability, to focusing on lowering costs and redirecting care to more cost-effective sites of care. So it flips the incentives immediately and arguably gets to that better result. And then lastly, expanding and strengthening those incentives around quality. So back to cost-effectiveness analysis concepts and policy development, we're focusing on broadening that policy framework from the very narrow approach to something which is more expansive, more population-based, and providing incentives for lower cost, higher quality effectiveness, and promoting other types of activities that will do the same thing at a macro level, providing funding to the state for the development of medical health medical records, electronic medical records, and also better care coordination all around, like our preventable readmission initiative. So we should also see, as we have these broader incentives applied to the payment system and to providers and payers, that you will find there will be more incentive for hospitals and physicians to engage in cost-effectiveness analysis and other studies, because there's more opportunity now to share the savings. As I said, if you align the incentives between physicians and hospitals, physicians will have much stronger incentive to look at things on a more cost-effective basis because they know they have the opportunity to share those savings, whereas before they would be giving up revenue that they otherwise would have had in additional volumes. Even with that, I would argue, and I'm not an expert in this area, but other countries, I think, have approached the issue of cost-effectiveness in a more deliberate and head-on way than we have. For instance, the UK has the National Institute for Health and Clinical Excellence, or the NICE agency. They make actual decisions about what the National Health Service will pay for. It's not that I think we're ready in the United States for that type of healthcare rationing, but I think that type of analysis, centralized, focusing in on the cost question, as Kevin had mentioned, you can't leave that out, could help guide this type of decision making and then be applied both at an individual practitioner or payer level, but also at an overall health policy level, guided by that idea of trying to promote better value for the dollar spent. So back to the future. We focused on these principles associated with cost-effectiveness analysis, but they've been around for a long time, some 33 years. And just recently saw this article in, again, the New England Journal of Medicine, again by Weinstein and a different author, Skinner. And it seems remarkably familiar. If we can induce hospitals and health plans to improve efficiency and not just cut their costs, then health costs in the United States will come down and outcomes will improve. It's only taken us 33 years. As Winston Churchill said, you can always count on Americans to do the right thing after we've exhausted every other possibility. I'm assuming we're at that position now, and there's a role for government to try to help us move in that direction. And I believe that Maryland's better positioned to do that than any other state. Thank you very much.
Great. Thank you very much, Mr. Murray and Dr. Frick. At this point, we will be taking questions both from our live audience here as well as from those watching online. And just a reminder, if you are watching online, you can email your questions to us to our email address at MAPHTC, as in Mid-Atlantic Public Health Training Center, at jhsph.edu. So while we wait for those to come in, I can go ahead and take some questions from our live audience. Yeah, right here.
I enjoyed both presentations. My first question is for Mr. Murray. I understand that quadrant 3 is the goal, is the ideal, and I think most things, speaking as a provider, we can get there with that. But I'm wondering whether there is any value in moving to some things to quadrant 4, particularly in this difficult economic time, and if so, is there the political will to do that?
Again, I think it gets down to the issue of trade-offs in quadrant 4, and that's perhaps where cost-effectiveness analysis can come in to see if the benefits associated with the quality improvements can be justified from an economic standpoint, and that's why those trade-offs are a little bit less certain. My own bias on this is that there's such opportunity for improvements in efficiency within the hospital industry, and when I say the hospital industry, I mean hospitals and physicians working together, that in most cases you can achieve both results. And particularly given the fact that we're just scratching the surface on the quality side, having just developed the metrics. So the focus should be on quality, but also there's a cost dynamic to improving quality, and the fact that there's such inefficiency that we need to be rigorous and try to force the direction more to that quadrant 3.
Okay, yeah.
First of all, 2 dynamite presentations, really great. Second question I would address to you, has this been recorded?
It has been recorded.
Okay.
And
We have an audience of about half a dozen people, 10 people, and really good stuff. Any preventive medicine residents here? No. Can you get that recording out and let people know that we really need to get the Mid-Atlantic. I mean, this is a great session, and don't let it die. Don't look back and say, why did we fail to get a good audience here, but rather get it out to people as a recording. Not as good as seeing people personally, but at least something better.
thank you. Yeah, that's a good opportunity to remind people, if those of you who were not able to watch it online, can see it on our website. It'll be archived on our website in about a week or 2. So, in fact, the director of the training center is also the director of the preventive medicine residency. So that'll be great. Thank you.
Plus, we both live in Baltimore, so we can come back.
Exactly. I guess I have a question for both of you. I wonder if you could speak to the current bill that's before Congress right now, and what kind of provisions are in that bill that might help improve cost effectiveness in the healthcare system nationally.
I'm not aware of much that's in the current bill that would help improve cost effectiveness nationally. I mean, it's mostly about getting more people insured, which is useful, and in the long term, if people are insured, then they should use care better, and it should keep them healthier, and maybe over the long term we would save money. But interestingly enough, healthier people don't always cost less in the long run. It can actually, I hate to put it this way, but it can actually be less expensive to pay for somebody who dies sooner of something that makes them die more quickly. And so I think that what we have before us is mostly about getting people insured, which is a worthy goal, but it's not about making the system more efficient under much of what's in the current bill, in my opinion.
Yeah, I would just echo those comments. There are some provisions in the Senate bill related to quality initiatives that they're very limited. Unfortunately, they're not these broad-based types of initiatives that we're able to experiment with here. Those may have a cost impact, but I agree with Kevin. It's the bill itself. It's just focused on trying to get people in the risk pool, and then hopefully you can take more active steps to address cost issues later. I think politically the administration realized they weren't going to be able, or they strategized they weren't going to be able to do both at the same time, so they focused on the insurance market, which naturally needed to come first.
Okay. Yeah.
I work in the Baltimore City Health Department and the Bureau of Maternal and Infant Care, and we're doing, we have a strategy to try to improve birth outcomes in the city, looking at reductions in infant mortality. And I'm interested in NICU costs and the cost of NICU and how home visiting services or any other services that happen during pregnancy can help to reduce some of those costs. The problem that I feel like, as a local person in a local health department, even though I work a lot with Hopkins on other things, cost effectiveness doesn't even really, or costs and how they apply to public health programs, doesn't even really enter into the conversation. And I'm wondering how we can start to introduce these topics in terms of even this, even a strategy such as specifically the one that we're working on. How do we start getting these conversations going? Because I'm not sure what's happening more on the academic side is really filtering so much certainly into the city health department.
Well, I guess, so why is it that it's not even entering into the conversation? I mean, it would seem to be of interest.
It's a lot of interest, but what I'm trying to how do we make this connection kind of start to happen a little bit more substantively?
Well, I mean, I think in many ways it comes back to many of the topics that that were raised in the second presentation, that you have to get the incentives aligned. And certainly, I made some reference to that, although not using the same phrasing, but just that, you're looking at a public health, local health department that's going to put up the money to try to improve the outcomes. It'll actually be potentially less revenue for the hospital if there are less infants in need of NICU services. So it's an interesting question about how to make that so that it financially works for everyone. Because it's almost always the case that one person's cost is somebody else's source of revenue. And so I think that some of it is just figuring out what are the ways that the incentives for better health, less spending, and then what else could be done with those resources in the hospital could all come together. And it's not always an easy topic to come to, because you do have to figure out what are the, what approaches or alternatives are there to get everybody on the same page. And there's no one answer that I've seen that's successful in all cases for that.
Yeah, in terms of, I agree exactly. I mean, it is all just a function of making sure that the incentives are aligned. In the case of the NICUs, if you're doing anything that provides better outcomes, but also erodes the hospital's revenue base, they're not going to be as cooperative. What our role is to try to align those incentives, but what you would need to do is try to see where you can figure out a way that they could actually generate savings by doing it, and raise that as an issue to them. Now we have to try to structure incentives to be more broadly applied to provide those incentives, but that's the conundrum currently. If there's a way that you can think of trying to make it a win-win, I hate that cliche, but a win-win for both public health and also for the hospital, then you'll get their attention. But certainly, we're a public agency. You can contact us if you have thoughts about how to approach this. We have a lot of flexibility and have created some hospital-specific and more innovative programs to try to get them to do the right thing.
Mr. Murray, I imagine over the time that this program has been in effect, you must have been able to keep political buy-in and buy-in from lawmakers over that time. How have you guys managed to do that?
Yeah, I mentioned the key success factors, and I may have mentioned this, I can't remember, but one of the big success factors is the governance and first of all, the statute, which was structured to be very broad, very general, but also give us a high level of political independence. Our budget is not funded by the general fund. It's a separate special fund, so we're not as subject to budget cuts. We report directly to the governor. We don't report to the Department of Health, so that we're not under the thumb of the Medicaid program, who is a large payer in the system. And generally, we've benefited by being in the state of Maryland. There's a mentality or philosophy to to allow agencies to be more independent and more of an emphasis on regulatory interventions. So all of those things together, the General Assembly and the governor has respected our political independence, and it's worked very well because of that point.
Is it easily transferable then, you think, to other states? Because you see at the federal level the problem that they've had with trying to include pieces of cost effectiveness. I mean, all somebody has to say is death panel, and you conjured up all the sort of fears that generally pervade.
Oh, I think there are challenges. Obviously, in the healthcare reform debate, there are discussions about trying to set up an independent, supercharged, commission like MedPAC on steroids that would be independent and also have some teeth. We're not quite there yet. We just haven't exhausted all our possibilities. But financially, economically, it will be an imperative. And I think that the financial interests in this country, both on Wall Street and manufacturing and elsewhere, will mandate it eventually.
Any other questions for our presenters? Okay, I think that wraps it up for today's grand rounds. And again, thank you very much to Mr. Murray and to Dr. Frick for a terrific presentation today.
Thank you.
Thank you.